to everybody that needs it, and at the price the individual and the community can afford. The implementation of the concept is flexible and different situations. It basically means every country, every hospital can have their own essential drugs list. In Yugoslavia, in the war, WHO was criticized. They sent a standard package of medicines for refugees, and there was chloroquine in it. They said, listen, in Yugoslavia, WHO is mad. Why do they send antimalarials to Yugoslavia? Well, it was a standard package, like in an army. There's in it what you need, sometimes more than you need, but what you need is there. Anyway, so you can have a national list of essential medicines. Now, and how do you make a list of essential medicines? Say, for example, here you sit in Uganda in a hospital, and you want to make like I was sitting in Ghana for 5 years, we made an essential drugs list for our own hospital. Okay, you start with a list of common diseases and complaints. All the common diseases you want to cover. And you make for each of them a treatment choice. And then say you have a headache, and you say, okay, treatment choice is paracetamol. Then you make a treatment guideline for the nurses and for everybody. Okay, headache, give 12 tablets of paracetamol. And that's the training and the supervision on the left-hand side. But at the same time, paracetamol becomes an essential drugs list. So that should be in the hospital and not diclofenac. And the pharmacy should now have paracetamol and not something else. And the paracetamol is what you're going to buy, or what you're going to supply, or what you're going to reimburse in your health insurance, and not morphine for a headache. You see what I mean? So it's the treatment choice that defines both the treatment on the left-hand side and the supply system and the payment on the right-hand side, and everything comes together in the patient. Then you can say, all right, a big hospital needs more medicines than a small place, and that is the concept of here this sort of bullseye. This is basically the concept of what you call a leveled essential drugs list. Now, the whole slide is all the essential medicines in the world. Now, you don't need that in Uganda. So you have the first bag is the green bag, where you say, okay, now what do we have registered? What is allowed? What is registered for use in Uganda? Okay, that's the first. And that registration is based on, let me say, the medicine should be effective and safe and good quality. But then not yet everything that's available on the market do you need in your pharmacy. I mean, in the Netherlands, we have 7,000 or 10,000 medicines registered, but you don't need all of that in your pharmacy, and certainly not in your hospital, and also in Uganda not. So then they would say, listen, we have 40 beta blockers are registered in Uganda. Okay, we take 2. With these 2, they are the most cost effective. These are the ones we're going to stock, and these are the ones we're going to prescribe, and these are the ones we're going to reimburse. So you have, within what is registered, you have your blue line, that is the national list of essential medicines. And you have levels of care. So you may have the outer blue line is a teaching hospital, maybe 600 or 700 medicines, and the district hospital, 300, and the health center, maybe 100 medicines, and the dispensary, maybe 25. Everything that's in the dispensary is also in the health center. Everything that's in the health center is also in the hospital. So you see, it's like an onion. And then you can say the area between the green line and the blue line is what you call the private sector. That is good enough to be in the market, but not good enough to be reimbursed or to give them free of charge to the patients. This is this idea of the essential medicines. Now here you see, this was from the Lancet, here you see the percentage of countries in different economic groups. So you see that have an essential drugs list. So the top one, the orange line, you see that's low-income countries. They were the first one to start. You see, it started in 1977, actually a few countries before, because WHO copied the idea from certain countries like Peru and Tanzania. But then you see that. But then you see the green line, so the lower middle-income countries, and then you see the blue line, which is the yellow line is the upper middle-income countries, and now even the gray line, high-income countries, they have an essential drugs list. Maybe not like a printed list, but they have what you call a reimbursement list. They reimburse certain things, but not everything. Yeah. So this is really what we say a global concept. I think in the world, 2/3 of the countries in the world now have a national essential drugs list or a national reimbursement list. Here you see an example of how it works in practice. It's from Kyrgyzstan, sort of you can say an upper middle income country, and we talk now insulin. We talk diabetes. Now you have insulin, basic human insulin. You can say the classical insulin, and you have what you call insulin analogs, which are newer, sort of artificially made insulins, which are effective, that's fine, but they are 10 times more expensive. Now in Kyrgyzstan, you can see on the left-hand side, 57% of insulin expenditure is on analogs. but they are 10 times more. So if you then have a hypothetical $100 budget, then of the $100, you have $57 is for the analogs. That's 2 patients, and your $43 buys 14 patients. So you see it in the graph. Currently, 57% of the budget is on analogs, but it's only 2 out of the 16 patients. Now, and then you see on the right lower side, it was submitted to the WHO expert committee and said, are the analogs now essential drugs? Insulin is, human insulin is, but are analogs also essential? And they compared the evidence and they said, no, they concluded that insulin analogs currently offer no significant clinical benefit over recombinant human insulin. So there's no clinical benefit and it's 10 times more expensive. And here you could see, if in Kyrgyzstan, they would now change the 2 patients, the red, the 2 patients, change them back to human insulin, that for the same money, they could buy 19 patients. So they, with changing back, stopping the abuse of a medicine that's 10 times more expensive, but not more beneficial, would double the number of patients they can treat with the same money. This is a typical example of the selection of essential drugs in a rich country. Now, and here we have something that I would like to do with you. This is a small real-life case. I will share the problem with you, and then I'll give you 5 minutes each for you to do the calculation. So be careful. This is a real-life case about the value of a new essential medicine. But it's the concept is what you say, marginal cost effectiveness, the cost benefit. Is a new medicine worth the money? Now, take it. And usually you do that in this cost effectiveness analysis, you do that on the basis of 1,000 cases. That's just a simpler calculation. So, and we talk now about the value of in that time, we talk about the 1990s, a thrombolytic agent that you can give to patients immediately after a heart attack. So you give them a thrombolytic in the idea that they will, well, there will be less thrombus and they will survive better. Okay, now the usual care, that basically means you put the patient in bed, you give a drip, the nurses, all of that, was 3.5 million for 1,000 cases. So if you give nothing, or the usual care, 3.5 million for 1,000 cases, and 120 patients die out of the 1,000. These are real figures. Then the usual care, which they used to give, a streptokinase, which is $200 a shot. You give 1 shot of streptokinase. I don't think they do it now, by the way, but this was at the time was the treatment. $200 per patient. And you see, so now with 1,000 cases, the total price is 3.7 million for 1,000 cases, and then 90 people die. So you really have a benefit. And now comes the pharmacist and say, oh, but I have a new medicine called TPA. Sorry, expensive, $2,000 per patient. But if you give that, and here you see then the bill goes up to 5.5 million per 1,000 cases, then 80 people die. So it is better, but it's expensive. And this is typically a difficult case. If a new medicine is better and cheaper, of course you take it. If it is equally good and more expensive, you don't take it. But this is something that is a little bit better and much more expensive. That's always difficult. Now, okay, we continue. The committee then said, okay, let's compare the SK, the streptokinase, with the usual care. So you see, I pay $0.2 million extra, and I save 30 lives. So that's about $7,000 per life saved. Survival, expressed in survival. The company said, okay, let's compare TPA with usual. So you pay $2 million, yes, that's true, but you save 40 lives, the difference between 120 and 80. You save 40 lives, so that's about $50,000 per life saved. That's well below the level of 80,000. And is it not so that in Australia, the life of an Australian is worth $50,000? You should buy my medicine. And then the committee said, hold on. You should not compare TPA with usual, which is sort of like placebo. You should compare it with the best available care, which was the SK, the streptokinase. So if you compare TPA with streptokinase, it is $1.8 million. That is the difference between the 2 million and the 0.2 million. So 1.8 million for the last 10 lives. That's $180,000 per life saved. This is what you call the marginal cost effectiveness. I should also explain to you a little bit about, say, okay, let's take for the first one, the streptokinase. You can say, okay, go back, you give everybody, so 1,000 cases, you give them streptokinase, and then you save 30 lives. Yeah, so 1,000 people have to take the medicine, for 30 to have a benefit. So that's what you call a numbers needed to treat is 1,000 divided by 30. That basically means you need to, for every 33 patients that you treat, one of them gets the benefit. Okay? Now, with TPA, you can say it's for 1,000 cases, you give it to 1,000 people and you save 40 lives. So that's numbers needed to treat is 25. So you give it to 25 people and one of them will survive. You don't know which one. Okay, if you now apply this system also to this marginal cost effectiveness, then you say, okay, TPA. So I give TPA rather than SK, and I have to give it to 1,000 people, yeah, to get 10 more survivals. So that is a numbers needed to treat is 100. So you have to give a very expensive medicine to 100 people for one of them to benefit that otherwise would have died. So you need to treat 100 times as many people for the effectiveness. Okay, this is one thing. So here you can see now that if the marginal cost is $180,000 per life saved, if you compare this new medicine with the existing treatment of SK, that's expensive. That's beyond what most systems are willing to pay. So that's one thing. So the marginal, it is a little bit better, but so much more expensive that the marginal cost is too much. But this is not the end of the story. And here it comes in now. Now, and this is where you have to, I will give you 5 minutes, and you take a piece of paper and a pen. The point is now, if you have a $500,000 budget, say in a hospital or in a province, and you're going to say, okay, we can either spend it on SK or on TPA. Which of the two are we going to reimburse? Now, I want you now to spend 5 minutes to calculate, if you use your $500,000 with SK, how many cases can you treat and how many lives do you save? And I want you to make the same calculation for TPA. If I spend my money on TPA, how many cases can I treat and how many lives do I save? I'll give you 5 minutes and I'll come back to you. All right, are you back in? So now I'll show you the answer to this question. Let me see, where are we? Hold on. Here. Let me explain to you. So if you spend your money on SK, you can treat 2,500 cases. And as it saves 30 for every 1,000 patients, you save 75 lives. But if you spend your money on TPA, you can only treat 250 cases. And although you save 40 per 1,000, you only save 10 cases. And this is against your intuition. Now you see that the better medicine is not so good if it is so expensive that many fewer people can get it. So the price allows 10 times more people to get the cheaper one. And so the marginal benefit is absorbed, is neutralized by the fact that you can only give it to few people. And that's why we say also in WHO that you should only give you should first make sure that everybody gets basic care before you spend expensive, sophisticated care for a few. Yeah, and this is typically the case that you can spend your money only once. And if you spend it like this, you better spend it on a medicine that's good enough and saves many more people because you can give it to everybody, rather than saving a few more people in a hospital for the rich people only. Yeah, so this links already to equity and human rights. Now I continue with other aspects. So far we spoke about selection, and you have to be very careful in your selection, and is it worth the money? And always compare the new medicine with the best available treatment that you had so far. Now we say something about prices. And the first one is a difficult one. Medicines are the largest health expense for poorer households. What I say is that in poor countries, poor people, they don't spend money on X-rays or hospital consultations. They just walk into a pharmacy and buy a medicine. And that's for them. So medicines are the largest health expense for poorer households. And in the public sector, so in the Ministry of Health, then usually it's number 2. After the salaries for all the staff, it is basically after salaries, what is spent on medicines is the second biggest budget line. And prices are high, and there's great variation. We have a standard way developed by Health Action International, that's an NGO, and WHO, on how to measure in a simple way medicine prices in a country. And you basically measure the prices, say in 20 pharmacies, of 30 medicines, a basket of 30 medicines. Now, they did it in Kenya, and 23 out of the 30 medicines were more expensive in Kenya than in the UK. Not, let me say, corrected for consumer power parity or something like that. No, just in absolute terms, more expensive. And why is that? Probably because the UK has a better system. There's no price control in Kenya. There's basically a jungle out there. So 23 are more expensive than in the UK. And also in economic terms, we always say there's very little price elasticity. If you have an elastic price, it basically means even if you charge more, people will still buy. But there's little price elasticity. The moment the price of the medicine is 10% more expensive, then 10% fewer people will actually buy. And especially, of course, the children, the women, and the poor. And we did a household survey in Uganda, and it turned out that about 1/3 of the people never got the medicine they were prescribed. Either had no money, it was too far away, or out of stock. They simply didn't get it. Why is it not? Sorry. Now here you can see also an example of these studies. Here you see the price in Kenya, which was, as I told you, was very expensive. This is one medicine, Lasix, furosemide. And then you compare it usually with the international non-profit wholesaler price. That's the sort of basic price. You just need a standard. Now in Kenya, not in one private pharmacy, but in 30 private or 20 private pharmacies, the Lasix was 106 times more expensive than the international world market price. And Armenia, it was only 6 times, and Sri Lanka only 4 times. It's still a lot, but you see they would do much better. Now, you can also express the price of a medicine, the box of medicine, in how many hours of daily wage or minimum wage. Now, in many countries like these, there is no minimum wage. So what we then say, okay, we say, what is the wage of the lowest paid government worker? So the sweeper, grade 1, step 1 in the Ministry of Health in Nairobi, what is he or she getting? That is the minimum wage. That's the lowest wage the public sector pays. Okay. And if you then translate the cost of a medicine in how many hours or days work, that gives you an idea. Now here you see Armenia was not doing so badly. Here we talk about 1 month of omeprazole, also treatment. 1 month of it. In Armenia, and you buy a generic, it's 4 days wage. So you pay 4 days wage for 1 month's treatment. But in Brazil, you pay for the generic 16 or 17 times, 17 days work. And if you buy the brand in the pharmacy, which most people do, 26 days of work. So 26 days of minimum wage to buy your 1 month of medicine. Cameroon, it runs off the graph, 56 days. So 2 months work for 1 month's medicine. Ghana, same thing, at least in the public, in the brand. There you see Ghana is not doing so badly with the generic. You can buy a generic for 6 days. Peru, going very well, only generics, 3 days work. Sri Lanka doing quite well. Here you can see, okay, the brand is 19 days work, but you can also buy a generic one in the public sector for 1 day's work. And that's the line I take. I don't care if the rich want to pay too much. I don't care, as long as you can get a good medicine relatively cheaply in the public sector. Then people can go there. Here you see the same thing. I like this slide also. This was Peru. Again, you talk about, this is 2 times a monthly medicine. So glibenclamide for diabetes and ranitidine again for ulcer. Okay, let's take the top one. Glibenclamide for diabetes, you really need it. Okay, if you buy the generic in the public sector, for 1 month's treatment, you pay 0.9, say 1 day. If you buy the same generic in the private pharmacy, you pay 2 days. And if you buy a brand in the pharmacy, you pay 4.5 days of salary. Now you see the same thing with the ranitidine, 1.3 generic public sector, 2.2 in the generic in the private pharmacy, and 8 days work in a brand in the pharmacy. So the best way for a patient to get a cheap medicine, the best medicine, is a generic in the public sector. Oh, so this idea that the free market and the competition will basically bring down the prices to the doesn't work like that. The free market doesn't work in the medicine for many reasons. The first one is that people have no idea what the real price is. Secondly, they're in a hurry. And thirdly, very often they're happy to find it in the first place, so they will pay whatever it takes. And of course, in that situation, the industry and the pharmacies, they abuse the situation. It's an inequitable power sharing. Okay, now about financing. Who is paying? And the Lancet Commission, of which I was one of the members, we made a heroic effort to make a calculation. If you take about 201, okay, about 200 basic essential medicines with which you can run a district hospital. If you take the cost of those medicines for all people in lower middle income countries, it will take you about 75 to 150 billion per year, depending on the range of uncertainty. And that translates itself in between $13 and $25 per person per year. $13 for lowest income countries and 25 for lower middle income countries. Okay, that's not a bad outcome, because the World Bank has estimated that to run a basic healthcare system in any low income country, you need between $60 and $100. So having between 13 and 25 for your essential medicines is logical. Most healthcare systems spend about 1/4 of the budget on the medicines. Okay, now let's look at it. Here you see a graph. Every dot is one of the lowest low-income countries. You can see Liberia, Haiti, Rwanda. You will on the right low, Sierra Leone. Okay, all these countries. Now this graph on the horizontal line, you see the total expenditure on health per at exchange rate per year. So you see, let's take Sierra Leone on the right-hand side. They spent about $70 per person on health. On the vertical one, how much of that do they spend on drugs? And you see the Sierra Leone only spends $4 on drugs. Hold on. So our list of 13, the line of $13 per head per year, that's the yellow line, the minimum. 3/4 of the lowest income countries spend less than that. So we have a real financing problem. There is simply not enough money in the system. And remember, this is public and private expenditure, everything together. Uganda, which I was talking about on many occasions, ends up also, I'm not sure where it is on the slide, but it ends up between $6 or $7 on medicine. Oh no, it's a little bit, sorry, 17. So they're a little bit above. Okay, I correct myself. But you see, many countries are far below. And this expenditure on medicine includes often the donations they get from the Global Fund. So in other words, 3/4 of lower income countries spend less than $13 per person on medicine. Now, this is something that the rich countries should now consider. So for the $30 to $25 per year, population can have essential. That takes about 75 to 150 billion per year. Okay, sounds like a lot of money. The world as a whole spends at least $1.5 trillion per year on medicines. But as I say, one-fifth of the countries spend less than 30 million. So the total money in the system is there. There is not a question that there's not enough money for medicines. It's a lack of equity. All the money for medicines is consumed by the rich countries. Now, and then you see that the Lancet Commission, they recommend that the governments must provide adequate financing to ensure the inclusion of the essential medicines in the public benefit package. And it also says the international community must fulfill its human rights obligations to support governments in financing a basic package of essential medicines for all, if they are unable to do so themselves. And so far, it's only done for AIDS, TB, malaria, as you know, the Global Fund, and maybe for family planning to a certain extent. But for example, for diabetes and cancer and many other very serious diseases, there is no international support whatsoever. Okay. Financing in many countries, if the government doesn't supply, you pay out of pocket. You pay when you are ill, you pay. And you can see in 33 lower income countries, more than half of expenditure is out of pocket at the moment of illness. And the moment of illness is a bad moment because that's the moment you can't work, you have no income. You may have already spent some money on other things. So it's a bad idea to leave it to people to pay out of pocket when they are ill. But you'd also realize that in many countries, the households have no cash at all. They only have, when they sell the maize once a year or something like that, they have money, but they have very little cash. And the key problem is that when you charge fees, everybody pays the same price regardless of economic status. Usually that's the case. While if you have a health insurance, the health insurance system is a sort of prepayment system. Everybody pays a premium, and then when you get ill, you get treated. Yeah, it's a prepayment scheme, and you share the risk. Now, the beauty of such a system, if you do it cleverly, is the following. It's what you call a triple equity shift. 3 shifts. The basic one is if everybody pays, then the healthy are subsidizing the sick. Then, very often, if you have an income-based premium, then basically the rich subsidize the poor. And what many people forget, the young subsidize the old, because in young age, you have much less health expenditure, and old age, that's when it counts. So this triple shift, you only achieve that by an insurance system where everybody participates. Now, and that's not the case. I mean, that's what exactly what Obamacare wanted to do, obligatory. Everybody is part, and that's the best way to share it and make it affordable to everybody. But out of pocket, it's not going to happen. And as in still so many countries, it's mainly out of pocket. We have 150 million people in the world every year suffer what you call catastrophic expenditure. They have to sell their land, have to sell their cows, they have to sell their property to pay the bills, go bankrupt. And 100 million of them are forced below the poverty line every year, including in the United States. So with out-of-pocket payments, universal coverage is impossible. This is also something. I wish I had AIDS. What happened? It was a part of a diabetes and insulin research, and they interviewed people in Cambodia, and the woman said, I wish I had AIDS because my insulin would be free of charge. My AIDS treatment is free of charge, but I have diabetes and I have to pay 1 month's salary every month for my insulin. Question I was always asking the students in Groningen, why are there so few adults with type 1 diabetes? Type 1 diabetes is what you call juvenile diabetes. So it starts young, your pancreas doesn't work, and you need insulin. And I always say, why are there so few adults with diabetes type 1 in Africa? Well, the answer is, they never became adults. They were dead before they were 18, because they died in childhood or in young adulthood because there was no insulin. The type 2 is what you call older age insulin, usually when you're overweight and that sort of, you have a partial pancreas. You may need insulin, but that comes at later age. But type 1, absolute insulin dependent, there is no adults because they never became adults. Now, in Tanzania, I'm involved in a program in Tanzania. The cost of the insulin, the syringes and the glucose monitoring for one child with diabetes 1, so usually a child of 10, 12 years old, takes 53% of the family income. That's a big problem. So half the family income. So there's no money for school uniforms. There's no money to support anybody else. That's a huge problem. These children die. Well, maybe now not in Tanzania because they're doing it better, but that explains why you have so few adults with insulin type 1, diabetes. Sorry. Why is the international solidarity for the treatment of AIDS and not for NCDs, diabetes and cancer? Basically, all the rich countries have said, listen, that's not you're on your own. AIDS, TB, malaria, okay, infectious diseases, yes. We don't want to get AIDS ourselves, probably they say. But NCDs, non-communicable diseases, you're on your own. And lifelong treatment with essential medicines for non-communicable diseases should be the first priority when introducing social health insurance. If you have health insurance in a country, the first thing you have to deal with is diseases which you can treat well. Treatment is not so expensive, although every month it can become expensive, which is life-saving. So let me say, especially diabetes, hypertension, there should be the first things to be including in a hospital package, in an insurance package. This is a famous slide from WHO. When you have a health system, a health insurance system, imagine you have the blue box is the money you have, and you're not covering everybody with everything. And now you can spend more money, or you need more money. If you expand to the left, then you can say, okay, we're now including in the insurance system people who are not yet covered. So to the left, I extend, but it's going to cost more money. Or I can extend to the back, I include other services. I'm going to pay for cancer care, I'm going to pay for X-ray, mammography, whatever. I can do that, but then the services become more expensive. Or I can go to the top and I say, I can pay everything. I can reduce the co-payment or reduce the own risk. So, but you can see already now that you cannot expand in all directions at the same time because it gets too expensive. You cannot give everything fully paid to everybody. It's not possible. So this was also the choice China made 2008 when we in WHO were asked to advise China. And China then chose that, okay, we are going to expand to the left. We are first make sure that everybody is covered with at least a basic package. Everybody gets basic stuff before we expand the package or before we reduce the co-payment. So that we have everybody equally treated, and we have also a register so that everybody is at least part of the system, even if it covers only part of the services. Yeah. So this is the 3 dimensions of the health insurance. Now, and a little bit on the system. So I've dealt with selection, I've dealt with prices, I've dealt with financing, and now I'm dealing with the system. Now that's a long story in itself, and it's getting to, I can't do all of that, but a few things. The first one is about quality. And I must say, when I was a doctor in Ghana, I was in charge of a labor ward, and we had people, the women who were bleeding, and you want to give ergometrin, and you give ergometrin, and the bleeding doesn't stop. And you give another ergometrin, and you say, oh, this is an atonic uterus, and she doesn't, it's still got this bleeding. And then you start massaging the uterus, or you start plugging it with bandages, and you do everything to stop the bleeding. It never, ever occurred to me then that the ergometrin simply didn't work. That it was lying ready in the windowsill for 2 months, and we know now that after 2 months it has no activity left. It's not stable. It never occurred to me that the quality of medicine was bad. And I think many doctors, they just say, okay, go to the pharmacy, get your medicine. That's it. And look here, we had in WHO real problems. 6 out of 10 tuberculosis combinations, the bioavailability was rifampicin. Rifampicin was in the tablet, but was not absorbed in the body. As a pharmacist, you can't see that. As a patient, you can't see that. So one of the key medicines was missing in the real treatment. 6 out of 10 artemisinin products in Cambodia are counterfeits. They are fake medicines. There's nothing in it. And less than a third of the oral medicine, generic oral family planning pills is not good. And that's a tricky one. Let me explain that to you, how difficult it can be and how difficult it is to see. Let me explain, for example, if you have aspirin, it's 500 milligram aspirin, that's basically 500 milligram aspirin and 25 milligram of glue, and you make it into a tablet. Yeah, okay. But then if you have a family planning pill, it is 1/10 of a microgram of a hormone in a big pill, well, a small pill, but there you have 1,000 times more glue than the hormone, which is only very little. So how are you going to make them? You have a big pot, you have a pot of glue, you put a little bit of hormone in it, and you mix it, and then you make tablets. Aha. If then you don't mix that properly, all your hormone is in one pill, and the other pills have nothing, and that can easily happen. Now, you look at the pills, looks beautiful. Strip, fine. Oh, you're going to sell. Pharmacist can't see it, patient can't see it. Sadly, after 9 months, the woman is pregnant. Or after 3 months, she's pregnant. Now, after 9 months, she delivers. And, oh, the stupid woman, she didn't take the medicine. There was no hormone in the medicine. So you really need a good regulatory agency, especially with generic medicines, unfortunately to say, and especially with sort of uncontrolled medicines from certain countries. And you need really to check that carefully. And you can only check that by going to the farm to the dossiers and the quality assurance in the pharmacy in the factory. You cannot just say, okay, we'll do a test. You cannot test quality to the medicine. You have to check the whole process. I'm just telling you this, so be aware when you hear about quality problems and the need to check properly. The same will apply to the COVID vaccine, by the way. Here is typically also an example. I love this slide. It's a bit complicated, but basically, this is misoprostol, a very important medicine for example, for abortion, but also for gynecological care. Okay, now on the horizontal line is the time. Every dot is one tested product. And you see, and the tested product should be between 90 and 110 percentage content. So that's the horizontal band between the two dotted red lines. So anything you want, if you test a medicine, you want it to be there. Even in time, it should remain within the specifications. Now, what do you see here? First of all, you see some medicines contain more than what should be. And then you see also this whole cloud going down to the right down. And then you see that more and more in some of these medicines, they lose their already after 1 year, it's only half what's in it. And after 2 years, nothing left. And you see a few on the bottom line, you see the square red boxes, the diamonds on the bottom line, 5 of them, they're fakes. There was nothing in it from the very start. There may have been glue or something else, but no misoprostol. Now, this cloud is typical for, let me say, quality of medicines in many developing countries. So you really have to be very careful about the quality. Okay, now here I have some more examples. I'm not going to read this, as you can read later. Anti-malaria medicines in Cameroon, anti-tuberculosis. Sometimes you see disasters, even you saw it in the Dutch papers that paracetamol was with toxic substance. Usually the substance is cheaper than what should be in there. There's usually a sort of somebody in some pharmacy, some manufacturer cutting corners and reducing the cost of the raw materials. Yeah, so these are some examples. There are many, many studied examples of bad quality medicines. So, in short, you have to be careful. This is also Kim Kardashian. Just for you to see how dangerous things are. In 2015, she posted an Instagram with Kim, and she said morning sickness, and you read it here. Oh, I was pregnant and I was sick in the morning and sick like a dog, but then I took that medicine and it was so nice and no problem any longer. But of course, it was medicine, moreover that is not working at all. But this was advertisements. So it went to 42 million social media followers, and the US FDA, she said, this is what they said, you have to take it out, false or misleading. And by the time the decision was implemented, the post had received nearly 500,000 likes and 11,000 comments. Now, this is what's happening. So you see now that medicine promotion, medicine advertisement, it can be a real problem. And you see it now slipping into this sort of, as I say, social media, websites, very dangerous, and half of it is uncontrolled. Let me see why I'm in I'm getting stuck. Okay, here we see something on the systems, and this was a slide we all had to laugh very much about. This is a sort of organogram of the distribution system in Kenya. And of course, it looks like a real problem. And let me explain it to you, and then you can see. If you go to the right upper corner, you see here antiretrovirals, AIDS medicines. Now, the second line, this is who is going to pay. Now, you see that in this case, MSF was paying, the Global Fund was paying, US government was paying, and the government of Kenya were paying. And then here, who is buying? So MSF was buying for themselves. US government was buying, the CDC was buying. Now, then who is receiving, who is distributing, and here that's the patient. Now, then you see, for example, that MSF, of course, had their own, the US government was from CDC directly to the patient. They were bypassing everybody else. The Global Fund went through Crown agents, and they gave it to the KEMSA central medical stores. MSF, directly to the patient. Now, this is a jungle. Can you imagine the poor government sitting in the middle and all these donors and all these medicines moving around them? Very difficult. A few slides. Here you see the Ghana, the outpatient department, the pharmacy. This is the waiting area. I was there in 2013. Okay, hold on. Where is the pharmacy? Well, here is the pharmacy. This window is the pharmacy. And if you then go behind, here's the same window, you see the lady sitting with her boxes, etc. And this is the pharmacy. That's what it is. in the whole hospital. So that's not so much. I was 2016, I was in Uganda. This is one of the clinics in northern Uganda, close to Sudan, quite a rural area. This is a mother and child care clinic. It's the afternoon, some people are waiting. It's not so busy, actually, you can see. And this is the pharmacy. That's not a box. This is the pharmacy. That's all they have. And you see maybe about 20 medicines, typically generic medicines, some maybe no injections, I suppose. This is what it is. So you see now that if I now say that 1/3 of the people who need the medicine don't get it, now you understand why. And then this is the alternative route. This is the Nairobi market. So if the clinic hasn't got, you go to the market. And the lady, of course, is not a pharmacist. She's a seller. And she said, oh, you have headache. Okay, you want the red one or the blue one? Or you have gonorrhea? Okay, yeah, I have a good one. Now, let me give you the yellow one. And then the patient buys 1 or 2 capsules. And the next morning they say, okay, I'm still not better. I buy 1 more capsule. This is how it goes. So access to essential medicines. Essential medicines have become a global concept. A lifelong chronic treatment with cheap essential medicines for NCDs can also lead to catastrophic health expenditure, bankruptcy and death. The lack of equity, lack of equal access can only be corrected by government through social health insurance with subsidy for the poor. And globalization and lack of regulatory control in low and middle income countries lead to many substandard medicines on the market, some falsified. And the free market forces will never achieve universal access. Active government policies are the only way forward. So now I'm ready to move you, and Jan, I hope you can arrange that, I can't do it from here, into discussion groups, about 10 minutes. And these are the questions, you can take all of them or you take one of them, which I want you to discuss. I don't think there will be much time for report back. We'll come back later to the answers to these questions, but I want you to discuss it and really think about this problem. So the first question is, will we continue in the Netherlands or in wherever to pay excessive prices for the new medicines like hepatitis and cancer? What can we do? And should we give financial support to the lower income countries who lack access to the most basic medicines? And is the lack of such medicines perhaps one of the reasons why so many migrants come to Europe? So with that, Jan, back to you. 10 minutes, and I propose that we start again at 10 minutes past 11.
Yes, so I will assign you automatically to with 10 or 11 together in a group to discuss these questions. And then perhaps Hans, you can type the questions for clarity in the chat box so students can relate to that.
Okay, I'll do that. Hold on.
And then we'll see you all back in 10 minutes. So creating room, so everyone is in a room in a couple of minutes, and we close the room in 10 minutes, you said, so.
Yeah.
Okay. There you go. I think everyone is back again, Hans. So
yes. Well, maybe have a few minutes. Is there somebody who would like to say something or ask something or say give some outcome of the discussion to these questions? Can we give the floor to anybody?
I had a question about the third question.
Yes.
Is it possible for migrants to when they come to Europe with a disease, are those countries in Europe obliged to help them?
Well, I think it depends on many different countries, but in most countries, there is a sort of obligation that people are treated equally. That's one of the reasons why you cannot absorb everybody who comes.
Yeah,
that's the big question. But it's also true that in some countries, for example, the healthcare for asylum seekers is not well done. Also in the Netherlands, etc. You come to we can come to that in one of the next sessions about human rights, and it is very good in every country to make a specific analysis. Is access to medicines, is it equal for everybody? For example, for prisoners, to mention just one thing, or for the poor, or for unregistered migrants. Can they go to hospital? Probably not, because they are afraid of being caught by the police and being removed from the country. So in reality, I think, even when migrants come here, it is not automatic that they will get equal rights straight away. But that's also the background why many people say, well, what if let me say, lack of healthcare, lack of development, lack of education for the children is the real reason for them to come? Why should we not give support locally or in the region or in the countries? Because that's the main reason why they're here. I mean, one of the big migrant crises, in my opinion, is linked to the fact that there's such visible inequity between the wealth here and increasing poverty in many places. Or let me say, our wealth goes up quicker than poverty is is disappearing. And so I would say, yes, there's such visible difference. And people are no fools. They say, listen, if I can't get it here, I should go and get it somewhere else. And access to medicine, access to healthcare is one of the reasons, I think, not the only one. Any more questions? Yeah? One more? If not, you can also put, from now on, I think you can put your questions on chat box. I'll have a few moments that we can, after each of the parts of the presentation, we can, I can try to respond to questions either live or in the chat box. So let's move on then, now to the second part, which is the part dealing with access to missing essential medicines. So I will continue with my slides here. You see now here, I showed you the Sustainable Development Goals. So far, we dealt with the first one, access to safe, effective, quality, and affordable essential medicines for all. And now we move to the second one, which is support research and development of vaccines and medicines for communicable and non-communicable diseases, primarily affecting developing countries. And here, there are some real problems with the current innovation system. And the first one, there's four at least, let's briefly discuss them. The current R&D, if you have the big companies doing the R&D, they usually focus on modifying existing medicines. So they tweet around, they look at medicines from other companies, and they do sort of me too, they imitate. And it adds very little therapeutic value. I will show you a graph in a minute to show that in the last 20 years, hardly anything new has been developed. So there's a lot of money going into R&D, but we don't get the medicines that we read, nothing really innovative, or very little innovative comes out. And then the biggest problem is that medicines with insufficient profit potential are not developed. Antibiotics, and we come to the vaccines also later in this presentation, but antibiotics is not good business, because you treat the patient, after 5 days he or she is better, and you lose a customer. So it's short-term treatment, not very profitable. Much better business is, let me say, diabetes or some lifelong treatment. That's good business. So this non-communicable hypertension, very good business, because it's lifelong treatment and lifelong customer. And you know what's even the best business? The best business is presumptive treatment. Sort of like, you talk to a woman, say, you're a little overweight, you are blonde. You may have pre-diabetes, better start treating now. That you never, and then you start convincing people, osteoporosis, another one, or menopausal problems, you start treating people for something that's not really a disease, or so you start selling medicines to people that are basically healthy. That is real business. So antibiotics is not good business, and you see very few little antibiotics coming to the market. Then neglected diseases, Ebola. There was an Ebola vaccine. Even already a long time ago, 20 years ago, there was Ebola vaccine, but of course Ebola is a poor man's disease. It was in Canada, and when the disease was sort of over, they stopped producing it. So when 20 years later, in a few years ago, when there was really Ebola, they just took it off the shelf and they could produce it. But in the meantime, it was never a good business to produce a vaccine for people that are too poor to pay. Now, I told you the pediatric formulations, children with AIDS are not in the rich countries. It's even worse. Some medicines, essential medicines that basically work well, are abandoned for lack of commercial potential. Say, benzylpenicillin is a basic penicillin, is still used for certain diseases, but it's stopped. There's only one or two producers who produce it because they want to use their production capacity for medicines which they can sell at much higher prices in Europe or in America. Anti-snake venom. There are hardly any snakes in Europe, not venomous snakes. You don't need it. And in Africa, of course, the one who's bitten by a snake bite is a child or a woman working on the field in a rural area. And they are not good customers. So they stop. So you see that basic essential medicines are not produced any longer. Some of them, that's really, they're abandoned. We call them abandoned essential medicines. And then sometimes something good comes out, some oncology, some hepatitis, as I told you, the sofosbuvir, or now for the first time after 30 years, a new medicine for TB, for multi-drug resistant TB. It comes out and it becomes very expensive because the companies, oh, yeah, we have so much expensive. Now look at what I'm showing you now here. This is a big study, 2014, okay, of 20 years. What were the medicines registered by the EMEA, so in the European Union, done by La Revue Prescrire, a very critical medicine analysis information magazine. And they always, when a new medicine comes, they help the doctors to understand what it is. And then they classify the thing. And when it's a real beautiful new medicine, they call it Bravo. Now, there's not in the 15 years in Europe, not one Bravo medicine. And then 2% was a real advantage, 7% some advantage, 20% possibly helpful, 51% nothing new, 14% not acceptable. And then 6% they don't know yet. Now you see that more than half is nothing new and not acceptable, or not acceptable. I mean, more disadvantages than advantages. So all this system where the research and all these companies together, the outcome is not really what we want. And I showed you on my first slide of the whole this morning, I showed you already the things that are missing. Now, a patent, you should realize a patent is, let me say, is done there to encourage investors to make an investment in time and money, in research, in development, and then they get it back by exclusive rights for a limited time, but in exchange for an early public disclosure of the invention. So they get the unique rights, but they have to make known what it is, so that science is being advanced. Now, patent system is a social policy tool, and it is to create benefits for society, but it comes at a cost. Because if you don't have the patents, now then I'll show you here. This was the pre-post, I'll explain to you. In 1995, the World Trade Organization, the sort of patent arrangement called the TRIPS, Trade-Related Intellectual Property Rights, became effective. That basically meant any medicine before 95 could never be put on a patent, and anything after 95 in developing countries, and after 95, all the members of the World Trade Organization, which is basically nearly every country, had to respect patents according to the new law, and a very strict patent law. Now you can see the effect here. Here horizontally you can see all the countries, and this is the number of patents they had on AIDS medicines, so the antiretrovirals. Okay, this was pre-95. And here you see after 95. You see all this kind of, suddenly all these countries had huge numbers of patents, which basically means that there was a monopoly where the company could set the price as it wanted. And here you see one of these graphs, well known. Here you see the difference. So the top line, this was a TDF, so the tenofovir-based first-line treatment for AIDS. And now you see the top line was one medicine, one combination, was the originator. And you see over all these years, no price difference. And even the second one, the red one, was another one, originator, no price. And now you see the black one, that was a generic one, and the lowest one. And you see the generic ones over time, they go from the $400 back to, say, $100 or less than $100. All over in the AIDS medicines, the first AIDS medicines around 2002 were between $7,000 and $8,000 or $10,000 per patient per year. The same medicine now sells for 62. 62, not 10,000. And the company says, oh yes, but the cost of research is so expensive. We have to spend so much money, and we have so many failures, etc. We have, of course, to divide the profit of the one over all the failures at the same time. And there's some study here, some published studies on the price of the drug development. And by Di Masi and by some other universities, well, what we should know is that, first of all, these calculations have never been really public. And secondly, these studies were all paid by the industry itself. So they are not independent. But $2.5 billion is a big myth. And it cost about $2.5 billion to develop a new medicine. But now we know, because there have been some public medicine developments. So in 2001 already, the TB Alliance, there was an international TB Alliance with money from Gates and others. They were developing new medicines for TB. And they said, well, we can do it, including the cost of failure, for about 76 to 115 million. That's not $2.5 billion. And DNDI, that's even much stronger information, Drugs for Neglected Diseases initiative. That's a big public-private production partnership with French money and a lot of money, Dutch also pay. And they have a huge number of pipelines for neglected disease, drugs for neglected diseases. And they have now developed 10 or 12 drugs from the very start till marketing. So they can really say we have a sort of average cost, and they say the R&D cost estimate for a new chemical entity, so a chemical entity for a neglected tropical disease, including cost of failure, anywhere between 100 and 150 million. So this idea that it is so expensive is of course something the industry would like to prove. And we know one reason why they can inflate the figures so much. And that is that, for example, they can say, okay, it takes us 10 years of investment or maybe 12 years of investment. And then they say, okay, if we would have spent the money on something else, then we would have made so much benefit, sort of like the economic cost of using the money. Now, if you then make a, let me say, a tentative or an imaginary benefit of 10% per year, then you can really say the money in the 20 years or something, or in 15 years of development has inflated a lot. Now, if you do that out of the $2.5 billion, half of it is this opportunity cost of what we would have earned with the money if we hadn't spent it on now that, of course, you can say is not real true development cost. And the Mercedes-Benz of the director of the research institute is also not development cost. You see what I mean? So these calculations are really not clear, let me put it like this. And where it is clear, where it is totally public, with public money, the costs are much lower. Then also there's something, the production cost. But look here now, let's go look at the second line, Sofosbuvir. The Sofosbuvir, which you know now is $84,000 for 12 weeks, but it can be made, and it is being made in Bangladesh, for $68, and another one for 136. That's the production cost. The bedaquiline, the only one single tuberculosis medicine, developed by public money, by the way, sells in the United States for $30,000 for 6 months. Production cost, 48 to 101. And you see all the other examples here. So most of these very expensive medicines, they have very low production costs. So this is big benefit. So the second reason that companies say, oh, I need the big money, what the companies usually say, they say, oh, well, we need to have big prices, and we have to use our patent time, and it's so short anyway. We really have to earn back the research money that we put into it. Now, you see, at production cost is very low. And now you see in 2001, we were shocked when the AIDS treatment in America was $10,000 per patient per year. Now you see imatinib, that's one of the breast cancer medicines, or leukemia, I don't know which one, somewhere between $30,000 and $100,000 for 1 year of treatment. Of the 12 cancer medicines recently approved by the FDA, 11 of them are more than $100,000 per treatment. So 11 out of 12 are more than $100,000 per treatment. That's the price medicines enter the market now. But the cost of production is not a justification. Let me put it at that. Now you see how medicine is really becoming a global issue. For example, the Sofosbuvir. Here you see a protest in different countries. This is, I think, in Germany. This was in Madrid. This was somewhere else. Patients deserve the right to life. In America, it is terrible because people can't pay the $84,000 if they're not insured. So you have now something like a buyer's club, because in India, Bangladesh, you can buy the thing for $300. Okay. Now, So, but of course, it cannot be imported legally into the United States because of the patent. But then you can send it to a patient. Individual people can send it. So now you have buyers clubs. So you have in India or Bangladesh, you have patient groups. They buy the medicine and then ship it to patients in America. Italy has approved that as a system because Italy can't pay $55,000 for one box of medicines. In your Erasmus hospital or in Groningen in the UMCG, also the hospital is paying $55,000 for a packet like that, which costs $68 to produce. What is the answer? Now, the Lancet Commission and many others, the United Nations high-level panel, they have recommended the concept of delinkage. We have to delink the price of the medicine from the cost of R&D. And how do you do that? So what you now say, and for example, we see that with the Drugs for Neglected Diseases initiative, the DNDI, they spend money, this is public money, Gates money, other money, on the development, say, of a new TB medicine. Okay, so then the industry works with it and small companies work with it, but the costs are being shared with everybody else and being public. So then when the medicine is in the end successful, the R&D has been paid. Then there is no justification any longer for a high price to the public or to the insurance company. That's what delinkage. And it would also solve a second problem, because you can also say, all right, we are willing to pay the R&D upfront for the medicines that we need. And so, for example, the missing, there's a lot of research on a heat-stable insulin, there's a research in oxytocin, there's research in antibiotics, there's research in TB, in AIDS and other medicines. So it's working now. And then also like sleeping sickness and trypanosomiasis and these sort of things, where there's no interest in the companies to invest because the patients are too poor. This is where the international community and the public sector pays for the R&D. And then afterwards, the medicine can becomes like a generic. You can give licenses to many different factories to produce the thing because the R&D doesn't have to be earned back. That is the process of delinkage. Now we come back to my original question. This is the Essential Drugs Committee, and this medicine was 84,000. What did they do? And in the end, in 2015, they listed sofosbuvir and 4 other antivirals as essential medicines by WHO. And actually, they said because it was so early and they didn't really know which of the medicines was better, and there were different prices, they said, listen, we can't say that sofosbuvir is better than any of the others, so we list them all 5 with a specific notice that a antiviral is essential, choose your one, and then hoping that competition would actually bring down the price. That's what the outcome of WHO advice was. But then we have to think now, okay, this is essential drugs, you saw that before, but now we can say the purpose, essential medicines are intended to be available within the context of functioning health systems, with good quality, and at a price the individual and the community can afford. So the fact that the medicine has now been listed as essential, even at $84,000, means it has to become affordable. The low price of the affordable price was not a selection criterion. It used to be in the past, but not any longer. So even an expensive medicine, if it is really effective and safe and saves lives, so it's cost effective, then it should become affordable. And what can we do to make it affordable? How can you bring down the price of 84,000? So what to do? And we have to realize now there that the patents, which are the main thing, are granted by governments. So they can also take them away. And if a patent obstructs providing access to a medicine, the government should act, nobody else can do it. Now, and patent law in many countries, and also in international law, allows for something that's called compulsory license. Let me explain that. If you have, say, Gilead has the patent on that medicine, it can give a voluntary license. It can sell the right to produce that medicine to any company. And then they get back a royalty. So there's a voluntary thing, and it's happening. I must say that's happening quite a bit. So they allow a company in India, but usually they say, okay, you can produce in India, but you can also only use it in India. You cannot export it back to New York. Okay, that's a voluntary license. But if the company refuses to do that, and for example, in the Netherlands, and only says, okay, 55,000 euros, that's the price, and we can't go lower, then the government can say, hold on, this is abuse of power. The patent is a social contract, and you are breaking it. because this is not the way to make the fruits of science available to everybody as quickly as possible. So if you have abuse of power, you don't want to give a voluntary license, you don't want to reduce the price, then we issue a compulsory license. That means we are forcing you now, and we allow somebody else to make it. And you get your royalty, that's fine, but I give, other than the patent holder, the right to produce or sell the product. For example, generic companies. And of course, there's still a payment of royalty. And this voluntary license, this compulsory license have been used a lot in AIDS. Now, what is the update on sofosbuvir last year? Okay, I showed you it can now be produced for $68 per course, for example, in Bangladesh and India. It's available for $300 to $900 per course in Egypt. So hold on. We sit in the Netherlands. You're not in America. You're not insured. You have to pay $84,000. Spend $2,000 on a Nile cruise in Egypt. Spend half an hour in a pharmacy, buy your medicine, and fly back to America. That's the best way of getting your medicine. You have it for $300, maybe $900. Or worse, better still, have a contact with patient groups between America and Egypt and say, oh, listen, buy me a box and send it to me. So that's what is happening. I must say that also now over the years, there is much more use of generic production and distribution through the Medicines Patent Pool. The Medicines Patent Pool is a central organization in Geneva that allows companies to put their patent in the pool, and from the pool, generic companies can buy the license, and the company gets the license, get the royalty back. This patent pooling is quite normal in telephones and cars. Everybody's patent pooling, airline industry. But in medicines, it was relatively new. It's now since 10 years that this is available. An easy way for the company to allow production in other places, and they just get the royalty back. Now, in Netherlands, we still pay around $50,000 per treatment, although they say there's a new arrangement, but it's unknown what is paid. That's secret. Of course, that's very, very bad. I mean, it's public money, and as a citizen in the Netherlands, you cannot find out what is my insurance paying for that treatment. But it will be somewhere between, I think, between $30,000 and $50,000 per treatment now, and same in the European countries. And of course, typically, the pharmaceutical industry, if they make it known that they sell it for 30,000 to the Dutch, then the Belgians say, okay, no. So they say, okay, the Dutch, you get your price, but silent. And the moment anybody else knows, we stop giving you that good price. So the pharmaceutical industry is really playing divide and rule. Now, and where the real, you can say now in the Netherlands, we can still pay 50,000. Although, you know what is the premium and of your health insurance. I mean, this is a lot of money for one person. The real problem is in the upper middle income countries, the countries like say Philippines, Indonesia, China, others, Mexico, Pakistan, where there's upper middle income countries, and they're being treated by the industry as rich countries because they focus on the rich people in these middle income countries. So in the long run, and that these are big numbers of people, is what I always say is middle income people in middle income countries. They are not catered for at all. Now, Thailand has issued several compulsory licenses, and here you can see what they have saved. So there were some usually cancer medicines. So let's take the first one, clopidogrel, I don't even know what it is. Originally the price $22 per tablet. After the government use, so the compulsory license, they said, okay, we're going to make it in our own government factory, 60 cents. So they saved 22. And so overall, in $1 million, they saved, out of a bill of $450 million, they saved $350 million. So that was a good way of doing it. Thailand is a very strong and progressive country in this regard. Brazil, similarly. So I would say now we have a little time, question answer. Are there any questions at this particular moment that you would like to put to me on this or anything else that you have in mind? Any questions?
So there are two questions, really, Hans. One is, can we have a break?
Yeah, I think that's a very good idea. Yes.
Yeah. So, and the second question is, if there were no more patents, do you think a lot of pharmaceutical companies would not have an incentive anymore to develop medicines?
Okay, let me answer that question and then we go for a break. That's good. Yes, the pharmaceutical industry would say we need the patents. And of course, what you should at the same time realize, of course, it is an incentive for them to invest in R&D, that's true. But I told you also before that R&D is not always all that useful. So we pay a lot of money. What you should always realize is that a lot of research the basic research is very often done by universities or by the Institute of Health. So this public money is in the basic discovery medicine. And then, of course, when a university, say when Groningen has developed a new medicine, that's nice, but they are not the production of marketing, all these clinics, they cannot do that. So at a certain moment when you have to move from the invention to a product that you can sell, university is very happy to sell the patent and leave that to the industry. So industry very often gets the inventions from either from universities or from small companies who have done a good discovery, and then the big industry just buys the whole company, usually because of one patent, and then starts making money of it. And then the patent machine becomes a big money machine. So it's a business model that the pharmaceutical industry will say is very successful, and usually their shareholders say it's very successful, and they have 18 or 20% return on capital every year, which is an excessive profit machine. So, and it is not producing what we want. That's why the delinkage, at least we don't say no patents anymore, but you say, okay, if they want to produce expensive medicines which are not really helping us, fine, let them do it. But at least let us now, with public money, develop the medicines that we really need. And I'll come back to that with the COVID vaccine. Develop something that we really need, and then make a good arrangement about the price straight away from the beginning. And see which company wants to participate. It's a different model. It's a model more like a commodity model. That means like a generic company. You have a medicine, you sell big quantities, not too expensive, and you sell to many people. So the profit is in the volume, not in the high benefit per tablet. That's the idea. So it's a different model where I think also, at least medicines, without patents, we can, and public investment in R&D, I think we can do a lot to fill the gaps of the missing essential medicines. Jan, let's stop here. And what time would you like to, we are well on time, so just tell me what time you would like me to start again.
Yeah, so up to you.
No. Well, how much, shall we say 10 minutes? Is that enough for people? That I start at 10 to 12 again?
Yeah. Okay.
And then we have one more hour that I can manage in 1 more hour with the rest of the stuff.
Okay.
Very good. Okay.
10 minutes then.
See you in 10 minutes. Yep. I'll start slowly. Good. Welcome back. Yes, indeed. It's good to have a break. I can understand that this is close to information overload. I'm sorry about that. I hope there will be a lot for you to reflect on, and suddenly later you will suddenly realize, oh, but what was I said at once, and then you will recognize it, I hope. Okay, I'll have a short excursion, maybe 10 slides or something like that, on human rights, because I really think that's an important concept now and in the future. So let me first give you a little bit of here, some basic ideas about human rights, for you just to know the basic stuff. Human rights concern the relation between the state and the individual. So not so much between individuals. It's important to note. And then they lead to state obligations and individual entitlements. So the state has an obligation and individuals have rights. Human rights are interdependent and they're interrelated. There are many, many human rights. And for example, in a recent UN assessment, you have the right to life, the right to liberty, a security of the person, right to food, right to health, right to freedom for torture, right to participate in public affairs, education, housing, social security, work, freedom of expression, fair trial, a lot of rights. But in reality, it's so that they are interrelated. You cannot have a human right here and then not a human right there. And they're all based on freedom from discrimination. Everybody is equal to the law. And if it is rights, and I say there are state obligations, then so there are state duties. So if somebody has a duty, then the fact that there is a duty means you also need accountability. Yeah, so rights imply duties and duties imply accountability. And the promotion of human rights is one of the very principal purposes of the UN. I've been in the UN for 25 years, and it really is, you find a lot of people there who strongly believe in these sort of principles. Okay, why is it not? Yes, okay. The first expression of the right to health was the WHO Constitution in 1946. And this is a literal, what you find on the first page. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That's right. So we talk about health. That's why it's called the World Health Organization, not the World Disease Organization. Yeah. So health is more than just not being ill. It is physical, mental, and social well-being. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, social condition, etc. This is Constitution, agreed by nearly all states in 1946. Now, the right to the highest attainable standard of health is the right to health. That's shortened. Of course, there is no right to, I have not the right to be healthy. I mean, at a certain moment I will get a disease, for sure, and for sure I'm going to die. But I have the right to the highest attainable standard of health. The state has to make sure that that it can be as healthy as possible, as my body would allow. Yeah, and shortened is the right to health. Then the Universal Declaration of Human Rights in 1948 has one article, 25.1. Everyone has the right to a standard of living adequate for the health of himself and of his family, including food, clothing, housing, and medical care and necessary social services. So again, this declaration, this is not a treaty, but this is a Universal Declaration, a very important document. It's about two A4s or two A5s, or two A3s. It's not very big. It's like a newspaper spread of rights. Very important document, just made after the war. Now, the right to health, to the highest attainable standard of health, is also recognized in many other, what you call legal instruments. These are international treaties. So, for example, the European Social Charter, then 1966, the International Covenant on Economic, Social and Cultural Rights, the Declaration of Alma-Ata, where the primary health care was being done, African Charter of Human Rights, American, and in 89, the Convention of the Rights of the Child, which was UNICEF, 89. It's very interesting to note that also the Convention on the Rights of the Child says a lot about child is entitled to education and a safe surroundings and that sort of thing, including basic health care. Now, the Convention, International Treaty, the Rights of the Child has been signed. Up till 3 years ago, it was not signed by 2 countries. Everybody signed except 2 countries, Somalia and the United States. And in the meantime now, Somalia has signed. So the United States of America is the only single country in the world that has not signed and not ratified the Convention on the Rights of the Child. Now, this International Covenant of Social and Cultural Rights is ratified, I think it's now 166 countries. It is an international treaty which is legally binding. So if a country is not obliged to sign or to ratify it, but if they sign, it's a legal binding obligation, in international right. Now, in Article 12, it recognizes the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. You can recognize it now. And in 12.2, it sort of says, okay, it's a number of steps that a government should take. Remember, we talk about government obligations, government duties. So steps to be taken by states parties, that means by the states, the governments, the countries actually that have participated, have signed and ratified in their own parliament. Maternal, child and reproductive health, workplace environments, and then prevention, treatment and control of diseases, and health facilities, goods and services. And I'm zooming in now on this because I want to say to what extent is there access to essential medicines part of the right to health. Now, then I go back. Here you say this is a legally binding treaty signed and ratified by an increasing number of countries. On the UN website, you can easily find it's more than 157 now. Then, once in a while, there are also what you call general comments, which are very authoritative statements issued by the International Commission on Economic, Social and Cultural Rights, usually prepared by experts, discussed by countries, and then adopted. It's not binding, but it is, as I say here, highly authoritative. Now, in general comment number 14 in 2000 is on the right to health. And it says the right to prevention, treatment and control of diseases includes creation of a system of urgent medical care in case of accidents, epidemics, and disaster relief and humanitarian assistance. So if humans are in problem, individuals need to be helped. That's basically it, accidents, etc. And D, the right to health facilities, goods and services includes appropriate treatment of prevalent diseases, preferably at community level, and the provision of essential drugs as defined by the WHO Action Programme on Essential Drugs. It's written in this highly authoritative. So if countries, they have signed the covenant and they want to know what does it mean, this is the highly authoritative statement that explains them. They should make essential drugs as defined by the WHO available to everybody. It's part of the health facilities, goods and services. So where are we? So health is a human right. That's in the WHO Constitution and in the Declaration of Human Rights. The right to healthcare includes the right to emergency care and health facilities, goods and services. That's in the Covenant, signed by many countries. And the right to facilities, goods and services includes the provision of essential drugs as defined by WHO. That's in the general comment. Now in yellow, that's my comment here. State parties are under immediate obligation to guarantee that the right to health is exercised without discrimination, and that concrete steps are taken towards full realization. What I mean is that human rights usually, there is this idea of progressive realization. That basically means if a country, say if Congo, signs the covenant in which it says you have to make essential medicines available to all your people, of course they cannot do that overnight. So then there is what you call progressive realization. You can take some time, but you have to work towards it. But there's always what you call two core obligations, which are immediate. The first one is you have to do something. You have to move forward. You cannot move backward. Even if it's slow, but you have to move forward anytime. And secondly, whatever you do should be available equally to everybody. So that's the non-discrimination. So building a big university hospital in Kinshasa is not good enough because not everybody can profit from that, not directly in that case. So you have to move forward, and you have to, it should be equally available to everybody. And I should explain to you now also, it's very important, this idea of the difference between, it's like a word game, between equity and equality. If I have $100 and you are 100 people in the room and I treat you equal, I give each of you $1. I treat you very equally, and that sounds fine. But the human rights principles said, no. Some of you are poorer than others, and some of you need it more than others. There is difference, the difference already in the current situation. Some of you is more rich than the other. So if I start giving my $100, I should give it to those of you that are least. And that's what you call equitable. If I distribute in an equitable way, it means I give more to the poor. If I distribute equally, I give everybody the same, which is not, and the rich don't need it. So that's why here in the yellow section, state parties are under immediate obligation, core obligation, to guarantee that the right to health is exercised without discrimination. So whatever they do should be equal for everybody. And that concrete steps are taken towards full realization with emphasis on vulnerable and marginal groups. That's where the equity comes in. So those who need it most should be helped first. Okay. Now, here you see this is also a moving target. I mean, but basically what you see, the second column is ICSE, the Covenant, 157 countries, regional treaties, 83, national constitutions. Actually, all countries, 193 at that time in 2002, all countries have signed at least one or two binding documents in which the right to health is enshrined. So what? They can sign whatever you want and shelve it. So what was it? And then in WHO, when I was in WHO 2006, we did a study with some students, and is it now enforceable? And basically the objective was, have individuals in countries now at a certain moment sued their own government and say, you signed a treaty and where's my drug? So the objective of that study was to identify and analyze court cases from low and middle income countries in which individuals and groups have claimed access to essential medicines on the basis of human rights treaties signed by the state. Now, the results very interesting, published in the Lancet. 71 cases have we found from 12 countries. Big search, a global search, very difficult. 59 were won, 12 were lost. Now, half of these cases at that time, 2006, dealt with AIDS. And others with leukemia and medicines for diabetes, renal dialysis. Very interesting. 38% were what you call public interest cases. They were like cases done in the public interest, usually with free support from lawyers. It was, of course, individual patients have to file, but they were supported by NGOs and by lawyers' collectives, etc. 20% were supported by NGOs. Now, and then very interesting, 93% of the successful cases were from Latin America. Most cases in Latin America, only 1 or 2 from India, South Africa, and Nigeria. Now, here you see the main findings. Here you see the countries. And what we found was that when court cases are won, usually at the High Court or Constitutional Court, it usually means that there was also something in the Constitution. So success was linked to constitutional provisions supported by human rights treaties. So if a country had signed a treaty and then put something in the Constitution of the same line. Now, a strong link with the right to life. So 66% of the cases were life-saving medicine. So if the medicine was life-saving, then you really had more chance of winning. Now, public interest. And the second bullet is very important also. Although it was individual cases, very often it has generated group rights. There was one case in Argentina where one person who was living far away and didn't get vaccination won the case, and it immediately was executed for 15,000 other people in the same situation. So the fourth bullet, government policies can successfully be challenged in court. There was one in South Africa, for example, where it's about 15 years ago, when preventive AIDS treatment for pregnant women was not given. It was only given in 18 clinics and not in the rest of the country. And went up to the High Court by some patients, said this is unfair, this is good treatment. But at that time, the president, Thabo Mbeki, he believed in olive oil and that people should take garlic, etc., to treat AIDS. And it was successfully challenged in court, and the ministry was forced to make the same treatment available to all South Africans in the country as soon as possible. So, as I want to say, there are many court cases that prove that even an individual, a stubborn individual, going through courts can win in many cases and then achieve something for whole groups of population. Now, okay. Now, of course, we can say, well, a court case is sort of, you do that when there's a government failure, and there's a general, the court case is a last resort. Actually, it's much better to make sure that your government program, your essential medicines program, is good from the start. So then what I did, that was 15 years ago, I said, okay, there was a good publication, WHO publication, 25 questions on the right to health. It's still a very good thing. You can find it on the web. And that's basically, that means, what does it mean in practice? And then I went through all these questions and said, okay, now what is relevant for an essential medicines program? And there comes out 5 questions, which I'll share with you in the next slide. But the general recommendation was that it's much better that the human rights thinking, the human rights framework is applied to a national policy or a national program from the start. If you make that from the start, okay, then there's much less need for court cases, etc., because you're doing well from the start, especially in the case of non-discrimination. So let me share with you the 5 questions. Normally it's a much longer presentation, but I shortened it for you. You can read, the references are in the end. You can read it. It's very interesting reading. But let me tell you, these are the 5 questions. If you sit, and let's, for example, do it in the Netherlands, or you can say, one of you, it may be go to South Africa or Tanzania or wherever you go to. I would advise you keep these 5 questions. First of all, which medicines are covered by the right to health? So if the government has signed and has made a program, is there a government, let me say, list of drugs? Is the government publicly agreeing to make that available to everybody? So what medicines are covered by the system? And is that a published list? Is that in the constitution? Is that in the law? You have to find out. Then, have all the beneficiaries been consulted? So when the government made the plan, for health insurance or distribution systems or an AIDS program, did it really consult with all the people? Did it go to the villages? Did it speak to NGOs? Did it speak to prisoners? Did it speak to minority groups? Did it speak to ethnic groups with different languages? In the Netherlands, can you say, is the medicine policy hasn't been discussed with representatives of our own communities, of Muslim communities, for example, or to mention just one thing. Now, okay, so have everybody been consulted? Probably not. Then, are there mechanisms for transparency and accountability? For example, is there a clear plan? Transparency, okay, we want to make available medicines to everybody within 1 year or something. And is it clear what the government is going to do? Has it been published? And then is there accountability? Is it listed who is going to do it? And if it fails, who is accountable? Is there a system? Then, do all the vulnerable groups have equal access to essential medicines? Say, take a country, okay, whatever country X. Are you sure that people in the prisons have good access to medicine? Are you sure that all your poor women and children have access to basic medicines? Are you sure that in India, that your Naga tribe somewhere high in the Himalaya, do they have equal access? And how do you know? Did you ever measure it? Did you ever go there and check? Did you go in Yemen to check maybe that girls get much less treatment than boys, which is definitely the case? Did you check in Pakistan whether women have equal access to men? Did you check in China who that is? Did you? I mean, usually you didn't check. And for that, you can, an average doesn't say anything. In South Africa, the average looks beautiful, but you have all sorts of areas or population groups or townships where it is much less. So you need what you call stratified statistics. You need to stratify according to separate between urban and rural, for example, or between rich and poor, or better, separate between the 5 economic groups from very rich to very poor. And as long as you don't know, you don't know. And then if anything goes wrong, are there safeguards? If you sit in your village in Uganda and you have seen the pharmacy box, and that's all there is, is there a complaint mechanism? Can you write to the minister? Is there an ombudsman? Has there ever been a court case in Uganda? No. Has everybody anywhere protested? Is there a way to protest without being kicked afterwards? So you see these 5 questions. These are typically human rights questions. And the basic thinking is, and you may still find it when you go to some African or other countries, that, okay, rural area, and the government in its paternal wisdom sends some medicines to help the people as a sort of charity. But human rights, right to health is not a charity. Human rights, it's justice as a right and not justice as a charity. You are entitled. And the people in these villages, they don't complain. They just accept it as it is. And that's where the human rights come in. They don't have to sit and wait. The government has a duty. They have a right. They have a right, and it's not a charity. Okay. Now, what are the practical recommendations to governments? First of all, write it in your constitution. Ensure constitutional endorsement of the right to health and the right to life and the right to non-discrimination. That should be in your constitution. I don't think it's even in the Dutch constitution, it's not there. We have it in other laws, but not in the constitution. Our constitution only says public health is a duty of the government, something like that, but nothing about individual rights. Now, then as a government, you have to specify the government obligations in social welfare and the provision of healthcare services and access, with emphasis on vulnerable groups. You have to make it clear, we as a government want to promise and we commit ourselves to this, that, and the other. Also, selection of essential medicines should be the basis for social security. That's a very practical tool. Then incorporate the rights-based approach, the 5 questions which I just showed with you, in national medicine policies. So consult and check and have accountability and have a complaint mechanism and things like that. You have to collect disaggregated statistics and monitor access by gender and by vulnerable groups. Then usually you have to create some legal instruments for enforcement and redress. I mean, is there a way to enforce? If government say some provincial government does not deliver, is there any way to force them to deliver better and redress the problem? And you have to report regularly on the progressive realization of the right to health. These are very practical advices to governments. Okay, now, what are the practical implications? There are indeed some moments that you can change the constitution, usually after big government changes. So, for example, in 1994, when we were writing this, some people are saying, Hans, you're getting megalomaniac. You are thinking that you can change constitutions sitting in WHO. And then we said, well, actually, yes, we can. Because, for example, in South Africa in 94, after the abolishment of apartheid, South Africa came to many international groups, including WHO, and say, how should we now write a new constitution? So the constitution in South Africa is very well written from a human rights perspective. So the new constitution, Bolivia did the same thing, Brazil. The many constitutions have changed recently or in the last 10 years, and usually they're getting much stronger on key human rights. And we have done collected, and that's a study one of my students in Groningen, PhD students. We have examples of all the constitutional texts in the world, and we have some clear constitutional text that can serve as a model for activists and policymakers and even legislators when the political opportunity arises, when countries are changing. Now, update in 2020, between 2006 and 16, the number of national constitutions with the mention of access to essential medicines as part of the right to health has increased from 8 to 13. We measured in 2006 and we measured in 2016, and it went up from 8 to 13. The same thing, national medicine policies. After 2004, they have much more human rights principles included than those before 2003. And in 2003, it was when WHO updated the guidelines. So that is the update. You see a slow shift that human rights and access to and medicines, access to healthcare as part of human rights is increasingly common in more countries. So the conclusion of this part of my presentation is most countries have signed and ratified one or more binding international treaties. The court cases to enforce it, they have been there, but especially Latin America. This right-based framework, the human rights framework, offers a very useful and practical tool to develop and implement national medicine policies, the 5 questions which I just showed you. And now we come to the next and the last part of my presentation. The rights-based approach is also very relevant for a new COVID vaccine. So I thought we would do any questions here, but I propose to go on, there's a few more slides, to the COVID thing, and then we'll take any questions and general discussion about all my presentations, if that's okay with you. So this is saving lives with the right medicines and the right to medicines. That was a bit of a pun. Let me go to the last presentation, hold on, which is the part 2 of the general access one. Here we are. So now the update on COVID-19. And first, I will look at it from the essential medicines perspective. That's exactly what you have heard from me so far. Now, I think that's a personal judgment that for COVID-19, I think the prospect of vaccines is now more promising than treatments. We have some treatments, but to find antiviral treatments has been notoriously difficult. Sofosbuvir was one of the few. And I think with vaccines, we are much better. But what you should realize now is that vaccines is bad business. Only a few companies are interested and often in partnerships. Let me explain that. I told you antibiotics is bad business. Vaccine is even worse. Vaccine, you give it to a patient or to a person and you lose a customer. That person will not come back. You only sell one.
Sorry, but I think we're still seeing the right to health presentation, so I think you have to share the presentation. Yeah.
Thank you very much for the thing. Hold on, let me do that differently then. Hold on. Where are we here now? Oh, I'm getting mixed up. New share. Sorry about this. Yeah. Oh, excuse me. I'm doing the wrong thing. Excuse me. Part 1, part 2. Excuse me for this. This is exactly what I didn't want to happen. Yes, I think I'm all right now. Am I okay now?
Yes, it's okay.
Okay, good. Let me quickly check. Sorry about that. Okay, so I was talking about vaccines, bad business. You sell a vaccine and you lose a customer. So only few companies are interested. And that's often the only way most of the vaccines are developed now is in public-private partnerships. They're actually doing the delinking already. So it is, and you have Gavi, you have all sorts of organizations that are willing to share the risk and also to guarantee, say, a new pneumonia vaccine or something to buy certain quantities in the next 5 years. Also create incentive for the companies. Basically, it's bad business. So it's only few companies are interested. Now, the third bullet point, for COVID, you can now see that there's large public investment, more than 10 billion. So you have seen now that's a lot of money for R&D for COVID-19. And there are 2, actually now maybe more. There are about 160 vaccine candidates, and 2 are very promising in the Lancet a few weeks ago. So the Oxford Zeneca one, and also the Wuhan CanSino Biologics. And both of them have now in recent studies, early phase 2 studies, more than 90% immune response and T-cell response. So that looks quite promising. Now, assuming now it comes through and it gets registered and saved, that all takes time. But my problem is the following. The global vaccine production capacity, it's bad business, it's only a few companies. It was around 1.5 billion doses per year. That's the total capacity early this year. And we have 7 or 8 billion people in the world. So it was never enough capacity for everybody. Now, WHO has just told me that it seems to be increased to around 4 billion doses per year. Still not enough for all people. So we'll have to ration. And you get, okay, I'll come to that. But what you should realize now is that the case of COVID-19 is not unique. It exposes existing problems of equitable access to new essential medicines. The same thing happened to AIDS. The same thing happened to sofosbuvir. So in that sense, it's not a new problem. For those of us who are in this business or in this science, it's just one more. And it's suddenly now, you see, when there was no access to AIDS medicines, many people in Europe and America didn't really care because it was not with them. When Ebola, the Ebola vaccine was only started when there was the first nurse in Texas who was infected. And when it was deep in Congo, nobody bothered. Now this COVID-19 is for all of us. So now you suddenly see, okay, there's a new medicine and can we do it quickly? Can we make it equally available? What is the price going to be? Is it a patent thing? All these sort of things come now and they hit us in the face because it's our own body that's now at stake. As such, and for the global health people, this is not a new thing at all. We have seen this many times before. Equitable access. So now we are basically facing insufficient quantities. I think the first quantities may come, well, actually the Zeneca one is already being produced, sort of pending the safety, where they basically trust that the safety will be okay. Being produced, I think around the end of the year, early next year, it will be on the market. And I personally think that the registration will go very quickly with all sorts of safety provisions, but I think they will do that quickly. But how to share the insufficient quantities of the vaccine? Is that on the basis of income? Rich countries first. It seems that of the first 1.5 billion doses that are known to be in production, 1.2 or something billion has already been reserved and bought by the rich countries. Only 300 million left for everywhere else in the world. Also, the Dutch government is preaching one thing and doing the other, and basically participated in a joint venture with Germany, France, and Italy, and bought 300 million doses already straight away for these 4 countries only. So rich countries first, is that the way we want to do it? Or manufacturing countries first? You see that also. Trump tried to buy one of the plants in Germany or in France, wherever it was, and say, oh, we're going to produce for our own country first. Is that true? Should we really have in the developing world, there's only a few countries, I think, Argentina, India, China, they produce. Most of the other countries don't produce. So they will not get anything at all. So is this the way we want it? Now, so this new COVID vaccine is a typical missing essential medicine. And I'm sure that as soon as it is available, WHO will very quickly put this on the list of essential medicines and essential vaccines. And that implies that equitable access for all who need it at the price the individual and the community can afford. That is the ethical position on this new medicine. So according to that, the COVID vaccine is a global good, a global public good, and all people are equal. And let's remember, inequities are unjust and preventable. That's what Michael Marmot said. He was the chair of the International Commission on Social Determinants of Health. Inequities are unjust, it's unfair, and they are preventable. So the distribution of the first vaccine quantities is really a political decision. Many countries go like America first, including some EU countries, as I said, including the Netherlands with France, Germany, and Italy. Now, what do we expect from the researchers and from the industry? Now, the public funders, this $10 billion, they really, as part of the agreement, must enforce plans for universal access as a condition for R&D funding to companies. There was also a company in Rotterdam, I think. And when asked, they were sort of vague. Yeah, it's not only going to be for the Netherlands. We only have some provisions for developing countries, but nothing really specific and nothing really said what price, what quantities, etc. And you see, when you have this in this concept of delinking, so you first pay upfront for R&D, so that these costs and risks are covered, then there's no need for high price. Now, I must say, when I read the newspapers about the AstraZeneca vaccine, is developed this way. There's a lot of money going into it, and I think they're selling the sales price is anywhere, I think, between $2 and $5 or something. So that's reasonable. No, but I'm sure it will be for $60 or for $100 in the private sector somewhere. Now, but the point is, as a funder, you can make what you call these access plans at the beginning of the funding. You say, okay, we fund, and when it comes out, then we should really have the following price structure and differential prices for poor countries and guaranteed quantities for poor countries, etc. That's what you call access plan. You have to make that upfront. The researchers, when they sit in their universities and in their different companies, they must ensure rapid access to intellectual property. And universities, when they should not sell the patents to the industry. That's very often happening, and especially in America, but I think increasingly also even Groningen. I think universities are so hard pressed for cash because they're not getting enough public money, and in America they don't get any public money at all. That when they have a successful patent and they can sell it for 200 million, oh yes, let's do that. 200 million, of course, is a joke for the industry because they will make billions of profits out of it later. But so universities should not sell the patents. They should, and if they do, they should really make it very specific access plans. Now, for students, you know, there's an interesting group called UAM, that is Universities Allied for Essential Medicines. Universities Allied for Essential Medicines, which are student groups that basically try to achieve just that for universities, what I call responsible licensing. They have action they carry action to force universities to be honest in this. And I think Maastricht was the most advanced on that one. And I think Maastricht University has a good central system now, setting the conditions by which university, let me say, discoveries can be sold to the industry and with patents. Okay, then also now that we are so, we need this vaccine quickly, researchers must share clinical data on effectiveness and the regulatory data to speed up the global production. The WHO is in a big research with, it's called Solidarity Trial. I think it's in 15 or 19 countries where, according to one protocol, vaccines are tested. Also because you need countries where the disease is quite rampant, otherwise you cannot test the effectiveness. And so not all the companies on their own, let's share that, and everybody does, so that you can quickly get to the 15 or the 20,000 patients or more that you need to prove it. And then when you make your regulatory file on the toxicity, okay, share that quickly so that the countries and regulators can already start looking at it, so that when the vaccine comes, they can quickly approve it or ask questions if needed. And the industries, say there's one industry that finds out it gets with a very successful vaccine, then they can of course produce maximum themselves, but they should issue the voluntary licenses through the patent pool, for example, and share production capacity. Well, it must be said that Pfizer, which is not the best boy in class, but Pfizer seems to have announced that, okay, if their vaccine is not the winning one, they would be willing to share their production capacity to produce the vaccine, the successful vaccine from other companies. So there are some signals there, because everybody would like to produce and sell, of course, but that would be the best way forward. And governments, now we come to governments. Governments have a strong role. Like the globalization and the free market forces will not resolve the problem of equitable access. The market will not do it. You need a strong government to steer the industry, the research, to negotiate prices for the whole country, to have to fund and support the poor, etc., etc. The market will not do that. Now, and in this case, like in any other case, the full transparency of the R&D funding and the public investment is needed. For example, this Oxford AstraZeneca thing. Okay, whatever the price comes out, and so far it seems okay, but at the same time, it would be really very interesting to know, okay, what money did AstraZeneca put in? What money did Oxford put in? There was a lot of money from Oxford University, I know that, because they were preparing for a corona vaccine already before this thing came. They had the chimpanzee production, whatever line ready, and they only had to put the corona bit in it, and they were sort of ready. They were very much prepared. Now, where did all that research come from? Who paid for it? All of that to check whether if a future industry claim like, oh, we paid and we took so much risk and that's why we need the price. And if you don't pay the price, there will be no vaccines for your children because we will be I would like to see that based on real information, and you don't get it. So full transparency of the R&D funding and the public investment is needed to resist high prices and also selective marketing. Because if you leave it to the industry, they will sell to Europe, of course, and America, and to the 5% of the rich people in India and Pakistan and Mexico who will pay $50 or $60 for a vaccine. That's good business for them. They don't care about the others. And you can only prevent that with strict regulations from the start, which were conditional to your funding. That's why I'm saying governments have the power through their large R&D investments, the 10 billion, to really ensure good access plans for lower and middle income countries. And some companies, some governments like Germany have already said, we will not accept industry monopolies for COVID. For COVID, we don't accept monopolies. So that means anything that comes will be subject to either voluntary or obligatory compulsory license. We are simply not accepting high prices based on patents. And Canada, Chile, Ecuador have done the same thing. They will use compulsory license if needed. Now, and I think the WHO and also to a certain extent the EU are working towards plans for distribution of the new vaccine to those most in need. And of course, in a country, including our own country, you don't have to vaccine 70 million people, there's no need. The first you start is the health workers and the vulnerable people, say the 60 plus with other diseases. And then not vulnerable, but vital professions, say the teachers and the dentists and the physiotherapists and that sort of thing, who are really in contact with a lot of people, and the elderly. That's where you start. So you start with 20 or 30% of the population in all the countries. So my conclusion here is now that access to missing and expensive medicines, so that was the part 2, access to expensive medicines has really become also a global issue. It used to be an issue in developing countries only with AIDS, but now it is really global. And for example, with sofosbuvir, it has been led to rationing of effective treatments in high-income countries. In France, they had a maximum budget for the sofosbuvir for the hepatitis C of I think $750 million, so €1 million, quite a lot of money. But it still meant they could only treat people with advanced disease. Well, you know that the young ones who have it already, very often AIDS patients or people with that, they would develop it also, and you want to treat them early, no money. Okay, the cost of R&D is heavily overestimated by the pharma industry and does not justify the high prices. I showed that to you. The high production costs do not justify high prices either. And in the future, R&D should not be paid through the high medicine process, the D-linkage, but funded upfront for an agreed list of missing essential medicines, like DNDi and MMV, that's medicines for malaria venture, and the TB Alliance, like it's being done already. So government and public money, they select the things they need, and they specifically pay for the research in those diseases, which are, let me say, economically not attractive. And then all countries, including the high-income countries, should use all available means, and there are many. I didn't go very deep into the subject of how you can control or reduce prices. But okay, there's at least 20 ways you can reduce prices, but it should include compulsory license, and very often they have to change the law to allow for that, to ensure equitable access to expensive essential medicines. Yeah, so there's many things governments should do, but governments have to do it. So I think I'm nearly coming to the end of my presentations, and this is a very important thing for you to take home. We have to recognize that the free market, as good servant as it is a bad master. We cannot take important global decisions on the basis of the free market alone. And the second one, which was in the Lancet Commission, there is no market failure. People would say, oh yeah, there's no children's medicines for AIDS, that's a market failure. No, there is no market failure. It is a policy failure to rely on the free markets to achieve universal health coverage. Okay, I close. Thank you very much. I hear your applause in my mind. These are two essential references which I can strongly recommend to you. The Lancet Commission report is long. It's 75 pages, so you're not going to read it. But as a reference, there's a lot of, so you can read that more like a book as a selective reference. If you want to look up something on essential medicines, that's the place. And the other one, the Medicines Law and Policy, that's a website and the blog of Ellen Hoon. That gives you daily updates on access to expensive medicines, D-linkage, R&D, intellectual property, COVID, the whole lot. So with that, thank you very much. I will close the sharing now. I'm available. I give the floor back to Jan, and I'm available for questions till we close. Thank you very much.
Okay, Hans, thank you very much. Are there questions at the moment? It has been a long session.
Yeah.
Anyone? No? Okay, so if there will be questions popping up, please let me know and I can share them with Hans, and then we can try to communicate through email on urgent questions, I guess, as well. So, okay, with you, Hans?
That's fine. About this human, let me not put a question, but just make a very, very short statement. Sometimes in other sessions, people have been asking me, such as human rights, and especially, let me say, students from developing countries. They then say, okay, but there's a right to health, and is it really enforceable, etc. And of course, what we would say is that if there's a bad government, then of course they're not going to think about human rights. But where it works well is when you have, let me say, good governments or good forces in a government who want to do well, and then the human rights framework is a very useful one. So you see quite a number of countries that have basically done quite well in applying it, very often moving in the direction of social health insurance. For countries like Thailand, South Africa are doing quite well. Costa Rica is one. You have a few states in India. They really do well. And also some of the, let me say, some of the silent countries in Africa. Ghana is not doing badly. Tanzania is not doing badly. Botswana, Namibia. These are the countries that are hardly ever in the press. There's no wars. It's very good. They're sort of quiet, and they are moving. Like what a friend, colleague of mine, WHO, always said. We always speak about developing countries. Developing countries. That's the real name. That's what they are. They are developing, and they really are. So with that message, I would like to close. When you speak about developing countries, yes, they are developing.
Okay. Thanks again then, and take care, stay healthy.
Thank you very much. Goodbye to everybody. And if there are some additional questions, then Jan can submit them to me and I will do my best to respond. Okay then, bye.
Okay. Thank you very much.